Hello, everybody. This afternoon, we're going to be talking about the new era of long-acting antiretroviral treatments. But what I want to talk about in particular is we already have very good treatment and prevention strategies with normal oral drugs. And how much better does long-acting antiretroviral treatment need to be to replace our current standard of care? We have all these new technologies for drugs for oral use or for implants, injections, and many long-acting antiviral drugs are still at an early stage. We have the Gilead capsid inhibitor, GS6207. We have islatravir from Merck that could be used in a long-acting formulation, broadly neutralizing antibodies from ViiV, long-acting formulations of tenofovir, alafenamide, and doravirine, all being developed, as well as the classics of cabotegravir and rilpivirine long-acting. Now, I'm going to talk about 7 key objectives for long-acting antiretrovirals that would make them good enough to replace our current standards of tenofovir FTC dolutegravir for treatment or tenofovir FTC for pre-exposure prophylaxis. So we need a treatment that's at least as good, if not actually better, than those treatments in terms of efficacy. In safety, we want a treatment that's very, very safe, similar to placebo, or just very small differences. Also, we know that the current treatments are very cheap to make. We want a treatment that's in the region of $50 to $75 per person year, and also a preventative strategy that's in around the same price range. Dosing frequency, ideally we'd want a treatment that could be injected or administered only every 6 months or longer, because that's the kind of visit frequency that you could see with asymptomatic people taking oral treatment in the future. It needs to be safe in pregnancy based on large databases and there have no additional safety problems. Drug interactions, it shouldn't interact with rifampicin or other drugs commonly used like hormonal contraceptives. And finally, we need to look at real-world use. How does this drug work in low and middle income countries in trials with wide inclusion criteria, much wider than the trials normally used for pharmaceutical companies to get drug approval? So we want to see the efficacy and safety in women and non-Caucasians, for example. So let's just think about how the current treatments measure up to these 7 objectives. So the LATE studies compared continued cabotegravir and rilpivirine with standard of care. But we need to remember, for non-inferiority studies to be valid, they need to compare to the current highly recommended treatments, such as tenofovir with dolutegravir for treatment or tenofovir FTC as PrEP. It's only if you saw a really big benefit of long-acting treatments over the current standard of care that you could justify higher prices. So if you look at the LATE-2 study results, there's quite impressive efficacy with 70% undetectable on the 4-weekly treatment and 94% on the 8-weekly treatment. Now, really, we should have a standard of care arm of tenofovir FTC dolutegravir for a valid non-inferiority conclusion on that study. And then if we look at that with treatment, if we look at prevention, we have the long-acting injectable cabotegravir, which showed superiority over FTC tenofovir as pre-exposure prophylaxis in MSM and transgender. So you can see here the risk of infection over time, and in blue, the people taking the new treatment versus the control in red. And you can see significantly slower infection rates, which is very encouraging. But we also need to look at the y-axis here and look at the size of the difference in infection rates. And if you've got a difference of 1 or 2 or 3% infections, how much more money is that worth? And we need to do health economic calculations on the additional dollars per infection prevented. It's a very important thing. We can't just say because a treatment is more efficacious, it should be rolled out worldwide, it should become the new standard of care, if it's a lot more expensive and harder to administer than current standard of care. So in terms of safety, can long-acting drugs be as safe as tenofovir FTC? We've done a meta-analysis of 13 randomized trials of tenofovir FTC as pre-exposure prophylaxis, and we saw no significant difference between tenofovir FTC and no treatment for either serious adverse events, grade 3 or 4 adverse events, bone fractures, creatinine elevations. So really, we need to see that kind of safety benefit when we're looking at a new treatment. You can see here in these second studies, this meta-analysis, you can see basically no difference in these adverse events between taking tenofovir FTC and taking placebo. And this is in 13 trials in almost 23,000 person years of follow-up. And then looking at the same comparison, if we look at tenofovir FTC versus TAF FTC, we don't expect TAF FTC to really be any better tolerated than TDF FTC. This is a meta-analysis of 5 treatment trials when the drug was used unboosted. And you can see in terms of grade 1 to 4 clinical adverse events, laboratory adverse events, serious adverse events, bone fractures, discontinuations for renal adverse events, really no benefit of TAF FTC over tenofovir FTC. So if we have a new treatment which is being introduced, we have a very high bar to overcome. It needs to be extremely safe to be preferable to the current standard of care. Then if we look at cost of production, if you think about the treatments that are being used for mass treatment in low and middle income countries, tenofovir 3TC dolutegravir costs $75 per person year. And that's for treatment. And then for pre-exposure prophylaxis, tenofovir FTC costs $54 per person per year. And these costs are declining over time. Now, if you think about a long-acting treatment, the costs of production could actually be a lot higher than that. And it's not just the costs of giving the drug, it's actually the cost of storing the drug and transporting it in a cold chain to make sure it remains stable. So long-acting treatments, if they prevent infections, they might save money in other ways. They might involve fewer clinic visits, less need for diagnostic tests. But we need to put all this into the equation. And if a new preventative treatment is a lot more than $54 per person year, or a new treatment is more than $75 per person year, we need to know why. So if you think about the generic ARV marketplace, and what are the advantages of pills versus implants in terms of mass production? For oral formulations, you have a modest upfront investment. You have a rapid shift from one API to another. It's very easy to turn the factory around. And you don't really need much of a market guarantee. You can go in with these treatments. It's quite easy to shut down the factory and switch onto something else. If you're looking at a generic company making long-acting formulations, you actually need a huge upfront investment for making the drugs. You have a slow shift from one delivery system to another. And you can't make drugs and other long-acting formulations in the same facility. There is guidance on that. So it's actually a much harder thing to do to make these drugs. In terms of dosing frequency, what's happening now is people are receiving larger and larger supplies of normal oral formulations every time they go to the clinic. They'll routinely visit the clinic either every 3 months or even every 6 months. If a long-acting treatment involves one, it's actually going to increase the number of clinic visits required. So it's actually going to cost more and be more of a burden on a health system. So we really need to think about a target of long-acting treatment for at least every 3 months and preferably every 6 months. There's been a lot of debate in the last few years about safety of drugs in pregnancy and unexpected signals turning up. The neural tube defects for dolutegravir being one example. Clinical obesity in before pregnancy could lead to more adverse birth outcomes when these obese women become pregnant. So we need to think about unexpected toxicities. For any long-acting formulation, we need a database of at least 2,000 women treated from conception with linked results on outcomes in infants. We already have this for tenofovir FTC, which is being used for pre-exposure prophylaxis. And remember, the antiretroviral pregnancy registry, which is the standard way to collect safety data, can take a long time. It can actually take 10 years to build up that data. So we need dedicated safety studies to speed up this process. Now, if we think about safety just on its own, and we think about how drugs have looked when they've been approved and then several years after initial launch, it's fair to say that a lot of the toxicities we've picked up in HIV have happened a lot later. Think about suicidality for efavirenz, not seen for over 10 years after the drug was approved. Stevens-Johnson syndrome for nevirapine, lactic acidosis for D4T, lipoatrophy for AZT, abacavir and the risk of heart attacks, dolutegravir and weight gain. It's almost like there's this happy time when a drug's just been approved and you have this honeymoon phase, and the drug's just been launched, the safety profile looks good, but the phase 3 studies had strict inclusion and exclusion criteria. And then you get this marriage blues phase in the long term when you actually find out the reality about a drug. New evidence emerges, new patient populations, larger sample sizes, you have new methods to study adverse events. And if we look at the current studies of cabotegravir, we can already see that the people in the main study of prevention were more likely to have injection site reactions. And there was some evidence for increased grade 2 adverse events, blood glucose, pyrexia, creatinine clearance. So we just need to think about these issues. Also, the people taking cabotegravir had a slightly greater change from baseline in body weight compared to the control group. So issue number 6, drug-drug interactions. We need to make sure that these long-acting combinations will retain their efficacy when they're used with key medications. And we know that rifampicin can lower the levels of many different drugs. And the protease inhibitors, for example, are hard to use with rifampicin. In the opposite direction, you can get drugs which lower the concentration of other drugs. So, for example, efavirenz lowers the concentration of hormonal contraceptives. So you need to be careful about the drug interaction profile of a long-acting formulation. And then finally, in terms of the real-world use of long-acting drugs, pharmaceutical company trials typically have strict inclusion and exclusion criteria. And pharmaceutical company trials may underrepresent women and non-Caucasians. We've recently run 2 studies in sub-Saharan Africa showing new results for tenofovir alafenamide that were not seen in the original studies that were mainly male and Caucasian. And we recruited almost exclusively Black people and a majority of women. So we need large independent studies of long-acting combinations in low-income countries to make sure that when we're talking about safety, we talk about all patients with all different races and sexes. Just as an illustration, if you look at the phase 3 studies of dolutegravir, you can see they only recruited 9% Black females overall. The worldwide epidemic is 42% Black females, the same thing for Black males. So you can see the underrepresentation of women and people of color in pharmaceutical company studies. So how long could it take to develop long-acting drugs? You've got to think about formulation development, which is longer than usual. Phase 1 and 2 trials proving the concept. Phase 3 trials need to be run for 3 to 4 years because you need to analyze the consequences, not just of being on treatment, but stopping the treatment given the long half-lives of these drugs. And we need real-life studies and pregnancy safety, which should be started as early as possible. So just to conclude, we have these 7 key objectives for long-acting antiretrovirals. And I've been through each of the issues that we need to think about. So this is actually a very involved area. We need to recognize that when we're researching these drugs in the future. Thank you very much.